This presentation is for Module 11, Nursing 150, Chapter 47. This presentation will discuss stroke, TIA, and also just discuss brain cancer at the end. So just a review of a neurological assessment. Make sure that you review all the aspects of this kind of assessment. A couple things to point out is loss of consciousness is the most sensitive indicator of a neurological status. So a change in a patient's baseline should make the nurse want to go further into a more specific neurological assessment. There's a couple of things. Those are checking the pupillary response, checking a patient's speech, checking those cranial nerves, so looking to see if they have a symmetrical smile, if their tongue can stick out, if they can hold their arms up symmetrically, different things like that. Muscle tone, temperature, any signs and symptoms of increased intracranial pressure, which would also indicate neurological dysfunction. And pupillary response is really important for the neurological assessment. Again, this is just reviewing some of the highlights of a neurological assessment to make sure you're aware of how to perform a neurological assessment if a neurological system dysfunction is suspected. This slide is just a picture of the parts of the brain that kind of is in charge of certain neurological functions. If you just kind of review this, you have your frontal lobe, your temporal lobe. And the reason I want you to look at this is if you hear that someone had some kind of an injury to a certain area of the brain, it'll help you understand the kinds of signs and symptoms that they might have. So for instance, if there's an optic nerve issue here, if there's something that is damaged, maybe if they have a stroke in that area, then it would affect their eyes, their vision, and everything. So just kind of review that a little bit, the AMP. So, if somebody says they had a temporal lobe infarction, it would kind of give you an idea of what kind of signs and symptoms that patient might have. This picture is listed in page 1012 of your IGGI book. It's figures 47-3, and over here on the right side of your screen here is basically talking about the visual fields that are corresponding to the injury that's occurring here in the brain. So if an injury is here, it will cause this type of a visual field disturbance. So they would have a blindness in that left side of their brain, total blindness, left eye, if they have a visual field injury here. So you can look at that picture and as according to the slide and kind of look at how it would affect your patient. So if they had their left eye was completely blind, right eye still had vision, then you would suspect an injury in the brain somewhere in this area around the optic nerve on the left side. An interesting thing to note, if you have damage here in number 3 area, which is around your temporal lobe, number 3 here is something called hemaniopia. So they have like partial blindness in both sides of their eyes, and it seems like that would be a really confusing disorder to have. So if they feel like they have partial vision, partial blindness in both eyes, then you would suspect something around the temporal lobe area. TIA stands for transient ischemic attack. So this is a warning sign that someone is having some vascular problems in the vessels of their brain. I like to compare this to stable angina that we spoke about in modules 10 and 9. So basically, there is some kind of an issue with their circulation and their vessels and their brain, and so they're kind of having a little short-term attack. So they'll have some symptoms that will be, maybe they have slurred speech, maybe they have numbness on one side of their body, maybe they have like a they're asymmetrical, droop to their mouth. A lot of times it's a speech issue that occurs, it comes on quickly. The thing about TIA is that it will resolve within an hour. If this occurs, if it resolves on its own within an hour, then it's called a transient ischemic attack. So essentially, there's some compromise in the blood flow, but it's kind of like that stable angina. If they kind of relax and rest, and then it kind of resolves. So, like I said, sometimes they can, by the time they get to the hospital, it might resolve. Then the big indication for a TIA is the fact that this puts somebody at high risk for a stroke. Oftentimes, if somebody comes into an ER with this, an hour ago they couldn't talk, their face was numb, their right side was numb, then it's resolved by the time they get to the hospital. A lot of times they'll admit these patients anyway and keep an eye on them, and again, kind of work them up to see what's going on to cause these symptoms. So perhaps if they can put some measures in place that can prevent them from actually having a stroke, that would be the great thing. So again, it's kind of a little warning sign, like, hey, hello, you've got something going on here that we need to look at and possibly fix so that it doesn't get into something as more serious as a stroke. Page 1005, chart 47-1, talks about the key features of transient ischemic attacks. It talks about the key signs and symptoms such as blurred vision, double vision, weakness in the arm, gait disturbance, numbness, vertigo, aphasia. Those are some of the key features, so make sure you review that. So it's just a picture to kind of help you understand the difference between a stroke and a TIA. So there is ischemic changes which happen typically due to some kind of a blockage within the vessel of the head of the brain. Here is this area, as you can see, and it's, like I said, it's very similar to like that atherosclerosis that occurs in a coronary artery, and the blockage is partially occluded. That can cause a TIA. That can cause those short periods of deficits, neurological deficits that resolve. A stroke or an infarction, this is an embolic stroke. That means there's a clot in one of the vessels in the brain, and that is where a complete occlusion will cause a stroke. So these TIAs, again, like I said, are a warning sign. Hey, we've got some blockage up here that we need to do something about before it completely occludes. Okay, a stroke or brain attack, like I said in the last slide, is just typically due to an ischemic event, which means it's occlusive. So there's a thrombus in there that has completely occluded a vessel in the brain and causing neurological deficits in the patient. It's important to understand that there are two types of brain attacks or stroke. There's ischemic and there's hemorrhagic. The goal in a patient that comes in with deficits that are signs and symptoms of a stroke, we have to first identify what kind of stroke it is. We have to identify whether it's a clot in one of their vessels or it's hemorrhagic, which means that one of the vessels has opened and it's bleeding, because it's very different treatment for these. They will have similar signs and symptoms. That's why it's important for us to determine which one it is, because the treatment is very different. So it's just a slide to kind of help you identify the causes of an ischemic and a hemorrhagic stroke. So ischemic is a thrombus or an embolus, which are essentially clots within a cerebral vascular vessel. And then hemorrhagic is typically due to an aneurysm. And we talked about aneurysms. Remember, aneurysms are when there's a compromise in the lining of the arterial wall, which could cause it to open, rupture, and bleed. Hypertension is another one of the main risks for hemorrhagic stroke, and that is because if their pressure is so high that it could actually cause the arterial wall to rupture and bleed into the brain. Arteriovenous malformation is something that people are born with. It's pretty rare, but it could be a different cause of a bleed in the brain. So this is just kind of explaining the ischemic stroke. Again, it's a clot in one of the cerebral arteries. A thrombus just means that it's a clot up there that's kind of accumulated from perhaps our atherosclerosis buildup and plaque. An embolus means that it's a clot that has traveled from somewhere else from the body up to the brain and blocked an artery, a cerebral artery. The number one cause of an embolic stroke is atrial fib. It's a cardiac condition where a patient has an irregular arrhythmia in their heart. And I'll explain this a little bit more in class because it's a little bit hard to explain this way. But basically, atrial fib causes a fibrillation of the atria. And when they're fibrillating, that means they're just kind of pulsating. And so what happens is the blood is not flowing through the heart from the atrial chamber to the ventricular chamber in a nice motion. So the blood is kind of curdling actually in the atria, and it thickens as it sits there, and it can create a clot. And the clot could be pushed through and manage to make its way to an artery in the brain and cause an embolic stroke. So anyone that has an atrial fibrillation, if they have a history of it, they will be monitored closely for signs and symptoms of an embolic stroke, and they will typically be put on a blood thinner as a prophylactic treatment to prevent them from having an embolic stroke. And the second major classification of a stroke is a hemorrhagic stroke. So this is bleeding in the brain. This is when one of the vessels is ruptured, and the bleeding in the brain will cause an increased intracranial pressure, which causes pressure on the brain, and that can cause signs and symptoms of a stroke, such as change in level of consciousness, such as slurred speech, numbness, things like that. So it's typically more acute. A hemorrhagic stroke is definitely a more of acute situation. And typically what happens is when somebody comes in with a change in level of consciousness, some kind of neurologic deficit such as numbness, tingling, aphasia, they will quickly go to get a CT scan of their head. The CT scan, the purpose of it is to identify whether it's a bleed or not. It rules out a bleed. So we take them to CT scan when they're having these symptoms to identify if it's a bleed. If it's a bleed, we're acting very, very quickly because we have to do what we can to stop this bleed and decrease the intracranial pressure. Page 1006 in your Iggy book, table 47.1, talks about the differential features of the types of strokes. It's a good thing to review that to kind of compare and contrast. They are similar. The signs and symptoms are similar, but there's some differences, such as the hemorrhagic stroke is typically an abrupt onset. An embolic or a thrombotic might not be. You might get some warning symptoms, such as a TIA for a thrombotic stroke. So just kind of review that table to kind of understand the differences and the similarities. It's just some important assessment that you should do in a patient that you suspect is having a cerebrovascular accident or a brain attack. Accurate history is important. The first question you're going to say is, when did the symptoms begin? We need to know how long this has been going on. It can help guide our treatment for whatever's going on with this patient. It can also help us kind of identify where in the brain the issue is. And we need to know what current medications they're on. The National Institute of Health Stroke Scale is the NIH scale. This is talked about on page 1010 in chapter 47, table 47.3. It is basically a score that you give your patient, and it's essentially a neuro assessment where you're kind of giving them numbers for what their neuro assessment is, and it helps determine whether they are meeting criteria of a stroke patient or not. So review that assessment, that NIH stroke scale. The patient is scored from 0 to 40. 0, no neurologic deficits, and 40 being the most deficits. The American Heart Association website talks about stroke as well, and it can kind of help you understand the NIH scale further if you need more understanding of it. There are a lot of different deficits that occur in your patient as a result of a brain attack. Make sure you kind of review some of those terms and understand them. One of them is proprioceptive, means aware of one's body position dysfunction. That essentially means that they're kind of unaware of one side of their body. The other thing to understand is sometimes a contralateral injury will occur. Sometimes if the nerves of the spinal cord, as they come up into the brain, they cross over. So the nerves that innervate the right side of your body, so the right arm, the right leg, actually crosses over to the left side of the brain. So if the the injury is in the left side of the brain, you're going to see contralateral symptoms, which would mean that it's on the right side of the patient. Same thing goes for if you have a boo-boo on the right side of your brain, the left side of your body is going to have the paralysis. And make sure you understand a hemiplegia, which means paralysis on one side of the body. Hemiparesis means weakness on one side of the body. So if it's weakness on the right side of the body, it would mean that there's a left cerebral hemisphere injury. So just kind of familiarize yourself with some of those terms to kind of help understand the definition and how to document an assessment on the patient's symptoms. Chart 47.3 on page 1009 is key features of stroke syndromes. And so you can kind of review that. Talks about the middle cerebral artery strokes. If something happens in the middle cerebral artery, the kind of signs and symptoms you're going to see. Just kind of review that to kind of give yourself an idea of how and why we need to document the certain deficits that a patient is having. That way the provider can, by looking at that assessment, determine where the potential problem in the brain is. Important assessment is always going to be airway. The ABCs, of course, if someone comes in, and then go further into the neuro assessment of a patient and document the exact findings of your complete neuro assessment. And the other really, really huge piece of that is, when did the symptoms begin? Again, that's going to determine possible treatment for the patient. As I said before, the CT is what we're going to do first. We're going to go in without contrast first and check a CT, and that will rule out a bleed. That's what we want first. We want to rule out a bleed. And then if we need to go in further, we're inconclusive with a CT scan, we're going to do an MRI to be more diagnostic. It's important to understand that the CT scan without contrast will show us if there is a bleed. It will not show us immediately if there is an ischemic stroke. That usually the signs and symptoms of that occur later, or that might be another reason to do an MRI. MRI demonstrates ischemic brain injury earlier than a CT scan. Okay, for your patients that meet criteria, this is non-surgical management of a patient with a brain attack. And this is for ischemic. This is a thrombolytic therapy for an ischemic stroke. This means there's a clot of some kind in a cerebral artery. So thrombolytic therapy is typically an early intervention. It's a clot buster. It's a standard of practice to improve blood flow to or through the brain. The idea of this therapy is that it will dissolve the cerebral artery occlusion to reestablish blood flow and prevent cerebral infarction. Retivase, or plasminogen activator, RTPA. Retivase is one of those drugs, the thrombolytic drugs that we use. There's typically a 3-hour window for this. So to be eligible to have thrombolytic therapy, we have to know when the onset of symptoms happen. So typically, that's a criteria for giving thrombolytic therapy, is that the onset of symptoms was less than 3 hours prior to treatment. So that's why one of our first questions when we have somebody come in, when did the symptoms start? We get a CT scan, rule out a bleed, and then if the onset of symptoms was less than 3 hours, we can administer the thrombolytic therapy. There are contraindications, according to the American Stroke Association, that people may not meet criteria, and that is any kind of major surgery in the last couple of months, any history of a head bleed, they would not give that to them. The latest recommendations from the American Stroke Association has sort of gotten a little bit more expanded on that time interval from 3 to 4.5 hours, unless they fall into some categories, and they're listed on page 1013. It talks about unless we could expand it potentially on a patient that doesn't have contraindications to 4.5 hours since onset of symptoms, unless they're age 80 or older. They have an INR less than 1.7 or equal to. Their NIH scale is greater than 25. So as you can imagine, a greater than 25 NIH scale would indicate that they have quite a few deficits, so it would not apply to them, or a history of both stroke and diabetes. They're just higher risk, and so we can't take that riskier decision to expand that window past 3 hours with patients like that. All of the risk factors, there is a risk for bleeding with this medication. It works well. It's been very successful in reperfusing the brain and breaking up that clot and getting blood flow to the brain and decreasing the deficits that a patient has from a brain attack. But there are risk factors involved, as you can imagine. The patient could bleed post-operatively, post-procedure of administering this medication. So our job as nurses is to really be on the lookout for those signs and symptoms of bleeding. This is going to be strict monitoring of this patient. And it's usually weight-based that it's administered. So monitoring vital signs frequently post-procedure. Observe for any signs of an intracerebral bleed or other bleeding. So you need to make sure that you kind of review the signs and symptoms of an intracranial bleed. And again, what you would be looking for is a change in a level of consciousness. You're looking for, a change in pupillary response. You're looking for a speech impairment that wasn't there before. So making sure that we're monitoring them for any signs that we could have created a bleed from giving them a clot buster. Chart 47.5 on 1014 talks about the nursing interventions during and after administration of RTPA. So make sure that you review that. Basically, it's fluids. They're going to be admitted to a critical care unit. Neurological assessments frequently during the infusion, and every facility has their own policy on how to do this, but just understand that you're going to do frequent vital signs and monitoring neurologically. Monitoring their blood pressure. We don't want their blood pressure too high or too low, so we're going to be very, very observant of what their blood pressure is and medicate appropriately. We're not going to put in anything invasive that they don't absolutely need because, again, they're at risk for bleeding, so we don't want to be sticking a bunch of IVs in them. We don't want to be putting an NG in them. We don't want to do anything invasive that's going to create a bleed because we've given them this RTPA that's going to make their blood super, super thin. Discontinue the infusion if the patient has any headache or severe hypertension, and then they will obtain a follow-up CT scan to make sure that it was effective and that there was not a bleed created by the RTPA. So the bottom line for this treatment is it's great, it's effective. Most places have established throughout the country something called a stroke team. In our city, the stroke team actually was, I guess I could say, invented, or it was pioneered by the University of Cincinnati. The program that the University of Cincinnati established has been copied throughout the country. the stroke team. So essentially what happens is if we have a patient that comes into our hospital, just as an example, to Christ Hospital, we call the stroke team from the University of Cincinnati and tell them that we have a patient that is probably a stroke. What they will do is they will review the chart. Sometimes they'll come on over. Sometimes they'll send a representative to come over to see the patient. Sometimes they'll just give us guidelines. Sometimes they'll give us recommendations. So basically what the whole point of this program is that they are the experts. They are the stroke team, and they will review a patient and they will help guide treatment for that patient. There are times when they say you need to send them to us, and we will pack them up and we will send them to the neuro unit and at the University of Cincinnati. And it's a collaborative effort to make sure that a patient is treated to the best of our ability in the city. And like I said, it's been copied around the country, that kind of collaborative care. The other thing they could do is sometimes they can monitor them from their facility. So it's really kind of a cool program that we could put them on a monitor and they can watch them there, and kind of help us guide treatment for the patient. Very cool stuff. So again, the thrombolytic therapy, a 3-hour window. There are a few cases that we could go more to 4.5 hours. There are contraindications for it. The biggest contraindication is a recent surgery, a recent head bleed, because we do not want to cause a rebleed. Nursing care for this patient that has received thrombolytic therapy is to monitor them closely as far as vital signs and neurologically. Some other drug therapy that would be appropriate for a brain attack patient. If some patients are not a candidate for thrombolytic therapy, so we would have to just give them anticoagulants, which would be the heparin infusion or Coumadin. If a patient has had a ischemic stroke due to a clot, they will be anticoagulated outside, of course, of the thrombolytics, but they might go home on some warfarin or aspirin to prevent them from getting any other clots. And they would probably wait like 24 to 48 hours after thrombolytics to restart maybe some warfarin or some aspirin on a patient. But basically, it would be a preventive measure to stop them from getting further clotting in their cerebral arteries. Calcium channel blockers, we know, lowers your blood pressure. It also can cause some vasodilation, so it could open up those vessels and decrease their blood pressure, which would keep a patient from having further brain attacks. Stool softeners are utilized in these patients because we don't want them straining when they use the restroom. It causes an increase in their intracranial pressure when that occurs, so stool softeners are appropriate. Of course, analgesics for pain. We would be careful with these analgesics. We would not want to give them anything that would increase their chance of bleeding. Tylenol would be appropriate, or maybe Percocet, which is an oxycodone with a Tylenol. But we might want to stay away from the non-steroidal anti-inflammatory medications for these patients because of the chance of bleeding. Anti-anxiety drugs, it's just to kind of help a patient work through the whole process of what has occurred to them, because we do not want them to get super, super anxious, but in doing that, creating another episode of a brain attack. So we want to keep them relaxed. These are some complications that can occur post-procedure, post-thrombolytic therapy, post-stroke attack. Rebleeding or rupture, like we've already talked about, they're hugely at risk for that, a bleeding after a thrombolytic therapy. Vasospasms, after we've sort of messed with their vessels in their cerebral hemisphere, that could cause some spasming in there just as a response to the irritation. Hydrocephalus just means an increase in the fluid on the brain, which can cause some significant neurodeficits as well. These are some more invasive procedures that could occur for a patient that has had a brain attack. Thrombolytic therapy we've already talked about. Neuroprotective drugs are anti-epileptic medications typically. And we'll talk about those more in the stroke portion of Module 11. But patients, again, we've kind of been in there irritated. We've irritated their brain. They are at risk for having a seizure due to the injury or the trauma that's occurred within their brain. So Dilantin or phenytoin is a drug. Gabapentin is another drug that might be given to a patient to prevent any kind of seizure activity in their brain just because of the trauma and the insult that's occurred from a brain attack. Carotid artery angioplasty with stenting. So angioplasty and stenting should be terms that you've already heard. Sometimes the carotid artery, which is the artery that leads from your heart up to your brain, it's the main passageway for blood flow to your brain. A lot of times in a patient who has arteriovascular disease, they will have clots in there as well, plaque and lipid buildup in there. An angioplasty is just exactly what we spoke about when we were speaking about the coronary arteries. They'll go in and balloon or plasty that plaque and stent it just like they could in your coronary arteries. Endarterectomy is a removal of a clot. That is another procedure that could potentially be done. Extracranial, intracranial bypass. They could, again, we talked about bypass surgery in the coronary arteries. This could occur in other arteries that supply blood to the brain. This would be a highly, highly risky neuro procedure that it would take very skilled surgeons to perform, but it is something that could potentially be a treatment. Post-brain attack, if a patient is had a significant event happen to them, especially with a bleed, because we said the bleed is an acute onset. It can be much more devastating than an ischemic stroke. A bleed can. It's harder to fix. So monitoring the intracranial pressure post-procedure, whatever procedure they have. And those are things, again, like a change in the neurostatus, a change in their pupillary response. You have to be very, very diligent in your neuro assessments in order to find these, be in tune to a change, a subtle change that could show you that they're getting increased intracranial pressure, because it needs to be identified and treated immediately. Safety unilateral neglect is if someone has had a significant injury, for instance, in the left side of their brain, and so the right side of their body is flaccid and damaged. It's paralyzed. It's something called neglect. Sometimes they're completely unaware of that side of their body. And so they could actually injure that side of their body because their brain cannot even identify that side of their body is there and how to control it. So it's something that they need physical therapy, they need support, they need guidance, they need education about, so that they don't actually injure any part of that body that they're kind of emotionally unaware of. Emotional support is very, of course, as with any significant health issue, you need to make sure that they have the support that they need in order to work their way through a significant change. If it's somebody who has had a significant brain attack, and again, if maybe one side of their body is completely paralyzed, that could be an extremely huge change in their life. So we need to get them the resources that they need and the education. Education as far as how to continue to become functional in society. What kind of tools can we give them? That's what you need to ask yourself. Who can we refer them to in order to get them what they need? Physical therapy, social services, home care, other things like there could be some difficulty with swallowing, chewing, eating, if they've had any kind of a injury to their brain that affects their swallowing. If they have any kind of right-sided droop to their face, this could cause a lot of difficulty in swallowing and eating. It's going to be a change in their diet, but we want to make sure that they get the nutrition that they need. Get them a swallow evaluation, things like that. The other thing is speech could be affected by their stroke or brain attack. So that would be significant. We need to find them the means to be able to communicate in society if they've had any significant impairment in their speech as far as aphasia or dysphagia. These are some potential nursing diagnoses, and I think we pretty much covered all of these in the last slide. So think about what your interventions would be for these potential nursing diagnoses for a patient post-brain attack. Moving on from brain attack to brain tumors. We've talked about tumors that occur throughout the body in past classes and lectures. Brain tumors, again, you know what that means when it's a tumor. It's cells that have divided in an unorganized manner and are causing issues with the normal organization of the tissue that it invades. Primary tumors originate within the central nervous system, and we do know that sometimes other tumors that originate somewhere else can metastasize to the brain. Typically, these metastasize from the lungs, possibly breast, kidney, or the GI tract. There are many, many, many kinds of brain tumors, the malignant or benign. On table 47.6 on page 1031, there's some information on the classification. The ones that stand out to me most are the malignant ones. If you see glioma, that's the ones that I've heard about mostly. Those are the most probably aggressive tumors, is the gliomas. And it's typically they're named after the tissue that they arise from. Manifestations of brain tumors in a patient vary from, of course, what kind they are. But some of the common key features are listed on page 1032. Chart 4710 talks about common brain tumors. Headaches is probably the thing that stands out the most. Maybe headaches that are new to a patient, that are very difficult to treat. Seizures, in a patient that did not have a history of seizures. Personality change in their behavior. I've heard a lot of patients, that's how they're diagnosed, as they just truly aren't themselves, and so they will kind of work a patient up to see if there's some kind of a malignant issue going on to cause the change in a patient. So any kind of neurologic change in a patient that's noted, they will possibly work them up for a brain tumor of some kind, because it's common that they will cause that. Treatment for a brain tumor is similar to tumors that we've talked about in other places in the body. There's that chemo and radiation. That it completely depends on what kind of tumor it is, how aggressive it is, where it is, if they can do surgery or not. One thing to be aware of, and we will, again, this kind of takes us into seizure discussion, is that a lot of times a brain tumor will put a patient at risk for seizure activity, so they will be put on seizure medications such as phenytoin, gabapentin, a couple other anti-epileptic drugs in order to prevent them from having seizure activity. Listed on this slide is, of course, analgesia, if it's causing them any pain. Dexamethasone is that immunosuppressant drug that, if it's autoimmune, if it's some kind of a immune process that could be causing the tumor, we will try to treat it with dexamethasone. The phenytoin I've already mentioned as a precaution. And a patient with a brain tumor who could potentially have seizure activity, it's very common. So a phenytoin, a gabapentin, any kind of anti-epileptic medication they could potentially be on. Ranitidine hydrochloride, we've already, that's a protective mechanism for their stomach, so they don't get a stress ulcer from all of the medical care that they're getting, such as chemo and radiation.
This stereotactic radiosurgery is a type of procedure that could potentially be a treatment for any certain type of a brain tumor.
This is just a list of further treatment considered for a patient with a brain tumor. Surgical intervention would only be if they had the opportunity to be able to remove a tumor in order to help the patient. Sometimes if it's a benign tumor, sometimes they can go in and remove a tumor to remove it because it might be pressing on other areas or causing increased intracranial pressure. As you can imagine, though, we're talking about a brain surgery here, so these are very highly specialized surgeries that would take a neurosurgeon specialist to do. So just basically have the understanding of a brain tumor, and basically as a nurse, your job in this is really comfort, keeping the patient comfortable, administering the medications, and knowing the side effects of the medications. So that's your pain medicine, your anti-epileptic medications, and just monitoring the patient for any change in neurostatus, and really kind of being, on your toes as far as any complications that would occur, such as an increased intracranial pressure. And bleeding, any kind of neurodeficits, just really being on your toes about monitoring the patient for that and supporting them, because this is as you can imagine, it's a pretty devastating diagnosis in some cases. And this concludes the lecture for Chapter 47, Module 11 for Nursing 150.